Welcome to the webinar today. We're going to be discussing how to improve nurse retention and resilience in acute care settings. My name is Iman Abuzeid. I am the CEO and co-founder of Incredible Health. I'm an MD by background. I've been in healthcare technology for the last 10 years of my career. Incredible Health, just is an award-winning hiring marketplace for healthcare providers. They use it to hire permanent and experienced nurses. They use our marketplace technology to do that. Our hospitals and health systems across the country, over 350 of them use the platform to hire permanent and experienced nurses in 20 days or less, which is much faster than the 82-day national average. So I'm honored today to introduce Sharon Pappas. She is the CNE at Emory Healthcare in Atlanta. She's been in that role for the last 5 years. Comes from extensive experience in nursing as well, and in nurse leadership. Four of Emory's hospitals have earned magnet designations, and Sharon currently sits on the American Nurses Credentialing Center's Commission on Magnet. In addition to promoting nursing excellence, she's also responsible for the nursing practice across Emory's hospitals, ambulatory care, and post-acute settings as well. Sharon, thank you so much for being here with us today.
Thank you very much, Iman. I'm very happy to be here and happy to be in the midst of the distinguished attendees. Maybe I just want to say up front that, I don't pretend as being the chief nurse at Emory to have figured all of this out. But like you, I'm on a journey of learning as I go and making sure that we stay connected, both as chief nurse executives and also as clinical nurses, to make sure that we're addressing the right things and listening and learning as we go, and certainly responding. So with that, I'll be glad to review the agenda if you want to move to the next slide, because I have a couple of disclaimers that I wanted to share as we look at this. What I'll be talking about in the next 40 minutes or so is the ability of an organization to pivot and to rebuild. Because that's what I'm spending a lot of my time thinking about. That's what we at Emory are spending a lot of time configuring ourselves in order to be able to accommodate that. I think we'll talk some about the importance and the benefits of interprofessional leadership during the pandemic and now post-pandemic as well. We'll talk some about resilience as well as about nurse retention. And then maybe I'll hand it back over to my Incredible Health colleagues to talk some about recruitment and hiring. So I would say to you all, let me tell you just a little bit about this fourth point here called retention. It is incredibly important, and I have never lived through a pandemic before, so I've never acquired any experience in really understanding what it's like to rebuild a nursing workforce after a pandemic. But we do know retention is an incredibly important thing. And I would love to be before you today telling you that we have now returned to our pre-pandemic rates of retention, but we have not. I will share with you that prior to the pandemic, we celebrated about a 12% turnover rate across all of our Emory Healthcare 10 hospitals. We really were proud of that. As you heard Iman say, that we have 4 magnets and others that are headed that direction. And so we really worked hard on creating a nursing culture where people would want to be happy, healthy, and doing what they love. And so our retention was around 12%. But here comes the pandemic, and for many reasons, some people were ill. Some people were like, I don't think this is what I want to do. Some people were, I think if you're requiring me to be this flexible, I think I'll just go travel and get paid a lot of money for being flexible, and various reasons that people chose to exit Emory Healthcare. And at the high water mark, our turnover was up in the neighborhood of 18%, which is about what we're seeing across the country. We've recalibrated a little bit in the last couple of months. We're now down to about 16%, with a quest to be back down to 12.5. So hopefully what I share with you today will be some of those things that will be helpful to you as we see them as work in progress, and I'll be able to share those and maybe get some of your feedback on your thinking about it too. I'll begin by saying, for Florence Nightingale, one of the things that she says that I always think about in times like these were there none who were discontented, the world would never reach anything better. And so I'm looking at this period of time at being one of those times when I'm kind of discontented with the way things are right now, which is really what's pushing me to be better. So if you'll move to the next slide, please, I want to talk a little bit about this picture that we put here in front of you. Move on to the, okay, that's a little different than the one I had in my deck. So, but that's okay. I'll be glad to talk about this, because what you see around the slide are people who are very focused. They're very people who are very determined. This is a team. There's multiple people working together, hopefully in concert and in connection with each other. You can tell what they're doing is an issue of high risk and high intensity. But behind all of that, you see compassion. And that's what kept them at this table. So I think an important discovery for me to think about is I think about our teams that cared for our many COVID patients that we had across Emory Healthcare. And we celebrated a very low mortality rate, which we were also very proud of, because it told me that these teams and their level of focus and their level of ability had really benefited patients. Our mortality rate was so low, we predicted that the patients that we saved when we compared ourselves to the national mortality rate of ICU patients would fill up a 747 jet. And so that was significant to us. But here was the difference. We in healthcare know that all the time we've got to be ready to pivot on a dime, ready to change gears, ready to shift into a different role than the one we were initially there to be in. And so you can do that once, twice, 3 times a day. But what we've realized is our ability to keep pivoting patient after patient, minute after minute, was one of the things that fatigued our caregivers, our clinicians, the very most, because they didn't have any way to pause, any way to breathe, any way to say, hang on for a minute, and until they went on to the next emergency. And so these were some of the things that we really tried to focus on as we entered our second surge, which was about this time a year ago. As we entered the 4th of July weekend, we saw a pretty significant, massive surge of COVID patients here in Atlanta. And so we had to pivot again. And it was the duration of the pivot, the duration of the change, and the intensity, and the expenditure of compassion, and all of these things that really brought our people to a level of exhaustion that we are now in the process of rebuilding. And when I say rebuild, we're not just talking about rebuilding our people. We're also talking about what did we learn from the pandemic that would really be a different rebuilding, that we should learn from what we did and rebuild those learnings into our new world. We also believe that we've got to rebuild us physically, from a standpoint of how many staff do we have? How do we use our decision making? How do we focus? How do we prepare our team? All of those things that we exercised so quickly during the pandemic, we're in a place of rebuilding those as we move forward. And so I would bet you that everybody on this call, all 120 of us, are in that process of rebuilding. And so I'll share with you today a few of the things that I think might be helpful as we are all on this journey. Next slide, please. So today, what I'd like to talk about is how our cultures impact people, and impact on a negative way, and maybe also on a positive way, because hopefully that's what we want to do more of. We're going to define burnout and well-being, and then identify a few current approaches to building community. And I'm not talking about the community that's out beyond the walls of our hospitals. I'm talking about the community within our hospitals, and the community within our units, and that our teams comprise is the community that I'm talking about here. Next slide, please. So if there is anyone on the phone that maybe has been practicing nursing as long as I have, you might recall a journal called Nursing 78. This actually came out 3 years after I completed my pre-licensure nursing education. And this was a journal I enjoyed reading. It had all kinds of relevant articles, but this was actually the first time we ever saw burnout show up in the nursing literature. So one might say, except for my first 3 years, burnout has been present among nursing for my entire career. And it's been something that you recognize in different ways, and we see it exhibited in different ways, but certainly we're seeing some of that now. But the title of this article was Burnout, the professional hazard you face in nursing. And it began like this: you became a nurse to help people, to make life and death the best it can be for fellow humans, to do good for humanity. But one day, you began to dread work. One day, you became cynical about nursing, and you felt ashamed. And that's how the article began. And it began by describing this phenomenon called burnout that over the last 4 decades of my career, we've really been able to refine and understand even better. Next slide, please. There were, on the heels of this first article, there were a couple of other articles that were published that were somewhat impactful and informative about what are some of the things we might do about burnout. And I would say to you, these things are still true today. It said the work environment was a key factor in burnout. These 2 articles, one in 85, one in 87, the first one from Heart and Lung, that said the stress, social support, and burnout of critical care nurses. And what they found across 4 different settings in critical care, that social support or being cared for by others varied significantly. And when it was absent, was predictive of burnout. Now, we nurses are social beings. Any of you that have ever designed a nursing unit where you eliminated the central nurses station probably learned a hard lesson that that's really what was the core and the drumbeat and the heartbeat of the entire unit, were where people came together and relationships were forged. So that was why this was such an attractive concept to me, because it talked a lot about how we interact as human beings in order to prevent burnout and to really support clinician well-being. The other article in the Journal of Advanced Nursing said the relationship between burnout and job satisfaction also existed, and that burnout was intricately related to the work environment, and that the higher the job satisfaction, the lower the burnout, and vice versa. And so these are important elements that, you know, even though this is back in the 80s when the research was published, is something that holds true today. And we'll talk a little bit about that moving forward. Next slide, please. So in 1981, the American Academy of Nursing launched a study to explore why some hospitals had better nurse retention and lower turnover than others. Now, this was during the 80s, and I don't know if any of you all were alive then or recall then, that this was one of our more significant nursing shortages. So this is why the American Academy of Nursing was so interested in knowing what are the hospital variables that attract and retain nurses, and what combination of variables produces a model of hospital nursing practice in which nurses are satisfied. And the study findings are listed there on your right. It said that certain styles of leadership, concept of autonomy in a setting of professionalism, how decisions are made, how professional advancement occurs, and how the disciplinary science of nursing is advanced. And do we measure outcomes for patients and nurses, and we act on those in order to improve? All of these were common findings across all of the hospitals that had better nurse retention. And so what I would ask you all, maybe move forward in the slide for me. There you go. I would ask you all what this reminds you of. You can stick it in the chat if you want to, but this actually evolved into a model that many of us nurse executives see as our evidence-based practice. And you are right, Nikki, it is magnet. These elements form the magnet model. And the way I like to talk about this is that as a nurse executive or a nurse leader, I see these elements as my evidence-based practice. Now, if you get really good at these, you should apply for the award and become a magnet designated hospital. But I would say the two don't necessarily have to act hand in hand. And you heard that I sit on the Magnet Commission, and I've learned a lot about the importance and the intricacies of each of these elements, but it's the interactive nature of these 5 findings that really creates that work environment there where we know nurses are happy, healthy, and doing what they love. So what happened to all of that during the pandemic? Well, I would say that if you were like me, we had a lot of leadership, but we also had a lot of management of people making quick decisions and also, really working toward a common enemy, which was the virus. We also maybe used our decision-making methods a little less frequently because we could not get together and we were just in such a pace of providing patient care that some of the other things fell aside. And so what I would say is that all of these things are part of our rebuilding and part of our pathway in order to recreate the work environment that we know is best for nurses. Next slide, please. So about 3 years ago, I had a fabulous opportunity. I was invited to join a consensus, a study committee who was commissioned by the collaborative at the National Academy of Medicine to actually produce a paper on clinician burnout. And you can see it at some of this reference below. This is not the IOM, or excuse me, the National Academy of Medicine report, but it's available in its full publication online for you to download for free. But as a part of the document that we authored, we put the definition of clinical burnout as the same one as the World Health Organization uses to define burnout as a problem associated with chronic workplace stress. It's not an individual mental health diagnosis, nor is it the same as depression. Burnout is emotional exhaustion, also known as overextension, depersonalization, also known as cynicism, and low professional efficacy, also known as inability to see your own personal accomplishment. And burnout occurs when you have a chronic, I say chronic, the repetitive nature of what we had to do during COVID, a chronic imbalance of high job demands and inadequate job resources. And so that's what leads to clinician burnout. Next slide, please. There are a few other people who have some things to say about burnout, and I put these references here for you to peruse later. One of the things also from the National Academy of Medicine is this publication about burnout among healthcare professionals, the unrecognized threat to safe, high quality care, which also triggered Dr. Shanafelt's publication listed below about physician and nurse well-being, 7 things hospital boards should know, because burnout placed clinicians at risk for poor patient quality and poor patient experience, which was why I believe it has come to such in the forefront here post-pandemic. And then a couple of Harvard Business Review articles that I think are interesting reads about the surprising power of simply asking coworkers how they're doing. Well, that's the social support that we saw in one of the earlier studies, and about how burnout at work is not just about exhaustion, it's about loneliness. Think about how isolated we all were during the pandemic and how you felt like, oh man, if I could just go to dinner with one of my colleagues, but we couldn't do that. And so the isolation and the loneliness, we had to get in other ways, like these perpetual Zoom calls. But, it's interesting to think about burnout in some of those other terms. And then finally on here, you see a reference to Leslie Kelly's research about nurse leader burnout, satisfaction, and work-life balance. And I'm worried about that right now because, even though I went to a meeting the other day and one of our nurse leaders actually said, congratulations, all of you, we survived a pandemic. And I think that's a wonderful reference point, but I also think how very important it is for us to think about the fact that our endurance is only going to be there if we have some balance in our lives, and we have to define that for ourselves and for each other. Next slide, please. One of the other things that I thought was particularly special during the pandemic is the interprofessional leadership that I saw occur. I don't know, probably like you, we stood up incident command, and the structure of incident command also included many teams like critical care, like emergency department, like surgery, like communication, like care model, like epidemiology and infectious disease. All of these, I think we had about 15 work groups that were solving problems around the COVID virus every single day. And what was really unique about those, I'll use Epi for just a minute, that team was co-chaired by our leader for infection prevention, who's a nurse, and the chief epidemiologist for the healthcare system. And it was just such a rewarding thing then to get a report out on our critical care group that was co-chaired by our director of critical care and one of our chief nurses. And so, these were the things that happened that I thought were just incredibly helpful, important, and kind of reassuring that when we're solving problems, that every disciplinary voice was heard and engaged. I have to tell you an interesting story about melding people and systems. We were at a point during the pandemic where we were making decisions about the reuse of isolation gowns, whether we should, save some of the ones who were not damaged or contaminated and actually save them for reprocessing later because we were having such a hard time getting isolation gowns from vendors. And so I thought, you know what, I really need the input of the System Practice Council, which is a council that's made up of all the chairs of the hospital and clinic practice councils across Emory Healthcare. And so I pulled that group together, which I was anticipating being about 20 people who would attend, to ask them their feelings, both about the gowns as also about the use of IV pumps outside the patient room. And when we got those people together, there were like 50 or 60 people on the Zoom call. And it was respiratory therapists, it was physicians, it was nurses who weren't on the practice council, but they just wanted to hear and listen to how we were thinking, hear the expertise of some of the groups who had studied this and were prepared to make some recommendations to us as to what we should do. And so this ability to meld the people and the systems together, I think, has left us stronger. And this is one of those things we don't want to leave behind as we move into this post-pandemic era. All right, move on to the next slide, and let's talk a little bit about well-being. One of the things about well-being that I'd like to share is that leaders who are focused on listening and learning and responding are those leaders that were described in some of the magnet work, but also those leaders who will be supporters of these positive work environments where well-being is grounded. You can see that well-being is essential to the therapeutic alliance between clinicians, patients, and families. Krasinski says something that healthcare is fundamentally a relational endeavor. Healthcare is fundamentally a relational endeavor. So think about that and think about how you're using relationships in order to create this therapeutic alliance. Now, we've all known about the clinician-patient relationship and how important that is. But think about the relationships between clinicians, among clinicians, and how we support each other, and how we're going to be thinking about that moving forward as we establish work systems that support well-being and not just dealing with the resilience of individuals. Well-being is eroded by occupational stress, and it's facilitated by stable relationships among individuals who provide care. And it's influenced by how we interact, how we make decisions, and how we lead. All of those are important supporters of well-being. Next slide, please. Because what we all know is so goes nursing, so goes the hospital. That's one of my lines. But if you really want to make that a more interprofessional statement, you can say that clinician well-being is essential for organizational well-being. So does your work environment foster communication, collaboration, no fear, social support? Because basically it takes all of that for us to have this clinician well-being environment. I'd like to tell you a story. During the pandemic, it was revealed to us that we had a lady, one of our residents in our skilled nursing facility here on the Emory campus, and that she was celebrating her 101st birthday in one of our ICUs where she had COVID. Okay, so if you do the math, you can subtract 101 from 2020 or 2019 and realize that you're sitting in about 1918. And guess what? This woman had also survived the other pandemic of Spanish flu and had herself, as a 3-month-old, contracted the Spanish flu. So here was a 101-year-old woman who had survived 2 pandemics and had been victim to both viruses. So once we heard that she had recovered and had returned and was COVID-free down to our skilled nursing facility, which is miraculous in itself, I made an appointment with her to go sit with her and talk. And it was a glorious afternoon that I got to spend with this lady. And I found out also that she was a nurse. She had immigrated from Chile to the United States as a teenager, and had actually gone to school in the US and had her master's in nursing and mental health nursing and practiced in Chattanooga. And so as I talked to her, it was during Nurses Week a year ago. And so I said, this is Nurses Week. And if I were to carry a message from you back to the nurses across Emory Healthcare, all 8,000 of us, what would that message be? And she said to me, I would tell the nurses to listen to your patients and listen to each other. And then be a nurse. Don't try to be a doctor when you're a nurse. Doctors and nurses are different. And the world needs nurses. And that was her message. And I thought a lot about all of the things bundled up in those 2 sentences. And I think that the world needs nurses because we are people who are drawn to relationships. We're drawn to be social beings. We are drawn to provide social support. And now it's our turn to do our best and to bring our strengths forward and be part of our organizational healing, and also be part of an organization that supports our own well-being as well. Next slide, please. So I want to talk about resilience just a little bit. You know, I think that every single generation brings resilience to the workplace. Every single gender brings resilience to the workplace. And every single race, nationality, culture brings resilience to the workplace. And all of those things only occur when people can be themselves and feel like they belong and feel included in how people interact, how they make decisions, and how they practice their discipline. And so all of those things are intertwined within healthcare. And I think that's why this is such an important platform for nursing. And one of the things that I realized too, as I did the work at the National Academy of Medicine, in that we worked from a structure that said, you know what, individual resilience is only half of the story. You also have to have work systems that foster well-being. You can't have an individual addressing their own resilience, place them back into a dysfunctional work environment, and expect that resilience to continue. This has to be something that we have to make sure our work systems are ready to sustain. Because, next slide, please, what's at risk are the clinical outcomes of our patients, the clinician outcomes, our own engagement and well-being, and our organizational outcomes if we don't do these things. So I want you to hear me loud and clear in that individual resilience is important. And you have not completed your work until you have also managed work systems in a way that support that resilience and sustain well-being. So it's about individuals and it's about the work systems. I love to show you this next slide because I think it tells the story about us nurses. If you look at the message here, you have 2 angels who've just gone to heaven, looks like they're in heaven, And one says to the other, sorry, I'm late. I had great nurses. Because our job is to provide overnight surveillance of hospitals, of patients in hospitals. That's why patients come to hospitals, because that's when they need overnight nursing care. And nurses use surveillance, both knowing how to recognize when something's bad's happening and knowing what to do about it is the secret of surveillance. And when we do that, we make every angel late to heaven because we have prolonged their life. And that's a job I take very seriously as a nurse and also as a nurse executive. And I ask myself, have I created the work environments that support that? So a very important part for us. Next slide, please. One of the favorite readers I have is is Dr. Amy Edmondson, who wrote this book called The Fearless Organization. And it's all about psychological safety in the workplace, because she says creating psychological safety in the workplace is important if you want to create a climate in which people are comfortable expressing and being themselves. And that's a big part of inclusion and a big part of belonging. And those are pretty essential elements if you really do want to optimize every clinician that is under your watch. One of the questions that she raises in there, and she's speaking to us leaders and saying we should learn to ask when we do our rounds, was everything as safe as you would like it to have been this week for your patients? To really be able to abstract not only the safety issues that relate to the mechanisms of our work, but also think about the safety issues that are part of the interpersonal nature of our work. And really, these are the things that are equally as important to instill safety among our clinicians. Next slide, please. One of my other favorite reads on the last couple of years was a book by Rana Oddish, who's one of the authors on this article that was in Harvard Business Review. And I'll tell you the story of one of the stories that she tells in the book. I hope some of you have read this book, and hopefully if you haven't, you go get it, because it tells the story of Dr. Oddish, who was a critical care intensive pulmonologist who actually ran the critical care unit at Henry Ford. And she became very, very ill. I won't give you the whole story, so you'll read the book and find out what the ending was. But she was very, very ill and almost died. And the book is about her experience as a critically ill individual. And I will tell you that she did survive and came back to write this book. And one of these stories that she writes in the book is a story about rounds. Now, all of you on this call have probably participated in clinical rounds in the hospital where you go from room to room to room, and there's a gaggle of people who are talking about the patient. Usually the resident presents the patient, and then others chime in, and they develop the plan for the day. Well, she was the attending, and she called on the resident to present the patient, and then she asked, this is something she learned how important it was while she was ill. She asked, do any others of you have anything to say? And the nurse who had been on the night shift all night said, yes, I want to tell you what I learned about this patient and their family last night while I cared for them, and went on to give the information. Well, Dr. Oddish observed that the resident just had smoke coming out of his ears after this had occurred. So at the end of round, she pulled him over and she said, what happened back there? I could tell that you had an emotional reaction to what happened. And he said, why did I not know that? She said, what? He said, what the nurse said. Why did I not know that? And she said, how could you have known that? You weren't here with the patient all night. And it just emphasized how important a culture of trust is, for us to be able to allow space for each other to share our own contributions and share power in decisions and comments that we make about patient, and have a certain proximity so that we know each other and have the ability to interact and make decisions together. So I love that story, and I hope you'll go read the book. Next slide, please.
Sharon, just one moment. If anyone has any questions, I know there's a few questions coming in through the Q&A. Please feel free to submit your questions, and we'll try to answer as many as we can towards the end here.
Terrific. Thank you. Oh, I'm so glad there's questions. I love
Yeah,
that.
there are.
Oh, good. We'll talk about those at the end. So when I think about retention, I think about how very important the people are to me. This morning, I was up on one of our big critical care units here at Emory, and I was talking to one of the nurses and the nurses absolutely love to tell their story of COVID. And I'm finding that this storytelling is an incredibly important element in, first of all, me understanding what the issues are and what it was like on the front line, but also it's therapeutic to them to be able to tell the story about what happened to them, both personally as well as professionally during a pandemic. And so we're starting to recreate some really important opportunities for nurses to do that. We also are realizing how very important it is for us to be able to reinforce the interprofessional aspects of what we do and really think about how important it is for us to look at every single task that we call on our staff to do. And I'm going to use one of your favorites, bedside shift report. And I don't know if any of you all have now have this all hardwired within your hospital, but we do not. I would say we're getting better, but it's not reliable yet that it occurs every time. But what if every time we did bedside shift report, we saw it as a relational endeavor? That we didn't view it as a task that you have to go check off a list somewhere, or you have to check it off in the EMR. But if it's a real relational endeavor where you're able to connect with a nurse that's on the off-going shift and say, wow, you did a great job tonight. I didn't know that you graduated from this school, that it's really a relational endeavor about, tell me about what happened last night with you and the patient. So it's less about just the technical mechanics of relaying a report, and it's more about finally asking the patient, is there anything we missed? And think about how powerful that is. And so we're in the process right now of really rethinking and revising our whole approach to bedside shift report. So stay tuned on that one. We'll have to report the data later. Okay, go on to the next slide, please. So what I would say to you is this whole idea of retention for teams, actions and conduct not only signal respect to each other, they model for others and signal to others that the partners hold each other in high regard, both as individual people and as representatives of different professional cultures or backgrounds. And I think this plays a huge role in retention. The nurse I was talking to this morning was talking about some of his colleagues that left Emory to go travel. And he said, we've started to see some of them come back. They're maybe on the night shift when they left a day shift job, but he said they're starting to come back. And I said, so why didn't you leave? Why did you stay to go and not go travel? He said, I stayed for my team. I stayed because so-and-so was staying. I stayed because I like working with Dr. Coop. And all of these reasons were why he stayed. It was about the relationships. It wasn't about the excellent compensation, which I'm sure that we're not the best in the world. We're not the worst in the world, but I'm sure that there's improvements we can make. But I think that he stayed for the relationships and for his teams. Next slide, please. So what I would tell you is to go out tomorrow, maybe even this afternoon, and seek shared purpose. Commit yourself to huddles as a relational endeavor, and not a huddle just to say, oh, it's Sharon's birthday today, or oh, it's so-and-so got their CCRN yesterday. The huddles are one where you can check in with each other and say, how are you doing? What happened yesterday that made you the most proud? What's your favorite thing to do today? And really get connected with people at a personal level, and a huddle is a good place to do that. Identify other practices that expose and reinforce that shared purpose, and provide social support, which is being cared for by others. And if you're an Emory Healthcare nurse, you know that we have a purpose here at Emory, and it says we improve lives and provide hope. And that's not just for our patients, although that's a big part of what we do. We improve each other's lives too, and we give each other hope. And I think that's very much a part of building community. So with that, I will say to you all, here's my favorite slide, because what this does, this is an Emory slide, and this is the very first time we prone the patient. And you can see that all around the slide, there are people who are focused, who are committed, who are very certain that nothing bad is going to happen to this patient as we flip an intubated patient from his back to his belly. They're prepared. They have their gowns on. All of their PPE is armed and ready. They have a partnership across all of the people so that they're working in tandem. And this is a communication here that says this is what we want to be. So if you'll switch to the next slide, you'll see the picture that I'm talking about. So very important things. And now you want to do questions and answers, or you want to go back to the rest of the presentation from the Incredible Health team?
Yeah, so let's go through recruitment and hiring in the next few minutes, and then we'll make sure we have at least 10 minutes at the end for Q&A as well.
Sounds good.
Great. So thank you so much, Sharon. That was fantastic, very insightful. One of the key topics, that's related is, a key reason that burnout can happen, that stress levels can increase, is if the units are understaffed, right? If there's simply just too much work or too many patients per nurse. And one of the key strategies for reducing burnout that certainly nursing leaders as well as HR leaders care about is making sure they have hired enough permanent staff. So I just wanted to go over some market data here. Let's go to the next slide, Allie. And go over some solutions as well. So nationally, what we're dealing with here is healthcare has become the #1 employment sector in the US. And it's been the #1 employment sector since 2018, as far as number of workers and as well as total dollars spent on the healthcare workers. And 1 in 8 Americans works in healthcare today. But our demand for healthcare as a country keeps going up as our population is aging. And we just simply do not have enough workers in the system. Of course, pandemics did not help. That just further increased demand on the system. But regardless, we just simply do not have enough workers and enough clinicians, whether it's nurses or doctors or whichever category you like, to meet that growing demand. So next slide. So when you look at the problem nationally, Sharon shared some detail around what's going on specifically at Emory, but nationally we're on track to be 1 million nurses short by 2023. That means we are missing 1 million nurses based on the demand that we actually have. And the annual nurse turnover nationally is at 17% right now. Sharon had shared that it was at 12% at Emory, it went up to 16%. They're working their way back down, and so it's great to see that Emory is below the national average. But certainly, just as you're looking across the country, some are at 17%, some are even higher than that. The other thing that's happening is the labor as a percentage of revenue keeps going up. So before the pandemic, it was at 48%. Labor as a percentage of revenue, it has actually increased to 55%. And what has driven that increase in labor costs is a few things. Yes, absolutely, there's more travel nurse costs that sometimes the system can incur. There's more overtime costs they can incur. But also, even the salaries of permanent nurses has jumped by about 10 to 12% in the last 12 months alone. And so this is a cost that every nursing leader and HR leader is struggling to manage and keep under control. And then the other piece is the days to fill. It is taking on average 82 days to fill a permanent nurse position today. Sometimes it's a bit faster for some teams, sometimes it's slower, but that's what we're seeing if you look at the permanent and experienced nurses. So we're taking new grads out of that number. And so you just look at the permanent and experienced, it's taking 82 days to fill. Next slide. So when we work with over 350 hospitals and health systems across the country, and this is actually data from the LA market, and it's real data, and it includes 3 different hospitals and health systems in that area, competitor A, B, and C. And across the top here, we just have different steps of the hiring process. And we're able to track, the number of days candidates are spending between each step of the process, and how long it takes to hire, essentially. So in the LA market, we have competitor A, who has the highest salaries in the market. We have competitor B, who actually has the biggest brand in the market. And then we have competitor C, who has the fastest speed to hire. And you can see that in the days and the hours that it's taking to make hires happen. And this is permanent hiring. And so what I wanted to ask everyone, and feel free to answer in the chat, is who do you think hires the most nurses in any given week or in any given month? Is it competitor A, B, or C? All right, we're getting quite a few answers in. I'll give it one more minute. So we have a lot of guesses. We have a lot of answers for C and a few for B. The answer is C. C by a long way, actually, in terms of the number of hires that they make in the market. What we are discovering is that, of course, things like compensation do matter. The brand matters, but as it becomes more and more competitive to hire nurses, it is actually those with the best internal operational processes for hiring that are able to get candidates through the fastest that end up hiring the most. And some key data that we have from our platform, our marketplace, is that 61% of nurses are accepting the very first offer they receive, even if the subsequent offers might have higher salary. And so the speed in which you can hire is turning out to be one of the most important factors for ensuring that your teams are appropriately staffed with permanent nurses. Can you go to the next slide? So in terms of where we come in here, we support many hospitals and health systems with our custom matching technology in order to enable these teams to hire high quality permanent nurses in 20 days or less. That's our claim to fame, and we're used by big health systems, academic medical centers, as well as community hospitals. Next slide. So in terms of what we do, we always, so how do we do that? How do we pull off this 20 days to fill for some of these specialized and permanent roles? And so the way we do that is, first, the employers are applying to the talent on our platform instead of the other way around. So it's a very nurse-centric and candidate-centric platform. And as you can imagine, the nurses absolutely love it. And then in addition to that, we have proprietary screening. We pre-vet and pre-screen all talent using our software in our service team in order to make sure that only the top talent is being served to the employer teams. And then the next piece is the custom matching. For every single employer we work with, we create custom matching algorithms, so it's a highly personalized experience. So let's say there's a nurse recruiter at Emory using the platform and they log in. It's not helpful to see 200 nurses. We want to make sure that they see only 5 to 11, right? Because those 5 to 11 nurses are the exact match for what Emory is looking for at that time. And then in addition to that, there's also data analytics, which the nursing leaders and hiring leaders love, because it enables us to identify bottlenecks and any areas of opportunity. Can you go to the next slide? So we work with academic medical centers across the country, including Cedars-Sinai and Stanford. We work with very large health systems like HCA and Providence and Baylor, Scott and White. We work with lots of community hospitals too. Certainly have tons of experience with both magnet and non-magnet, with union and non-union. Essentially every type of hospital and health system at this point has used the platform with great success. And this is just listing just a few of our clients. Next slide. So one of the new models that is really showing up in hiring when it comes to nurse hiring specifically is highlighted on this slide. And this is a slide from the Stanford team. And every team has roughly the same 8 steps in their hiring process, all the way from sourcing, making sure the phone screens are completed, hiring manager interviews are completed, offers are sent, offers are accepted. And so what many teams are now adopting is a model where you can get a software provider like Incredible Health to do the heavy lifting in the first 4 steps, right? So Incredible Health is handling the sourcing, the pre-screening, making sure the candidates are actively looking, and making sure that phone screen is automatically scheduled. And then at that point, the in-house talent acquisition team takes over. They're completing the phone screen, they're completing the hiring manager interviews, sending the offers, and getting the offers accepted. And this is really a new model that many talent acquisition teams are adopting. Because in the same way that we want nurses to be operating at the top of their license, we also want recruiters and hiring managers to also be operating at the top of their skill set too. And what this model enables is that it enables recruiters and nursing leaders and hiring managers to do what they do best, which is relationship building with each other between the recruiters and the hiring managers, as well as relationship building with the candidates, with the talent. And really things that can be automated, like these items in the first few steps of the process, collaborate with a software provider or marketplace technology like Incredible Health in order to do that. And it's ends up being a much better use of recruiter time and hiring manager time. Next slide. And so this is the kind of data that we'd replicate for our teams. So these are again, the steps in the hiring process. And this is a team that is using our platform. So without Incredible Health, it was 66 days to fill, whereas with Incredible Health, it was 19 days. Where we have the biggest impact is on time to source. So finding the talent is actually usually what really elongates the days to fill. And we can get it down from 44 days down to 3 days. We also shave off days later in the process too, with things like automated phone screen scheduling. But ultimately, this is the kind of results that we replicate for the employer teams that we work with. So it's a true collaboration, a true partnership with the in-house talent acquisition team. We do not employ any recruiters ourselves, and it's our marketplace and our technology that's delivering the majority of the value here. All right, so let's do some Q&A. Next slide. Several of you were asking if we're going to share the presentation. Absolutely. So this webinar is being recorded, and so we will be sending the recording out afterwards as well. And then we'll also be following up with an email that will not only include the recording, but it'll include some of the academic articles that Sharon cited, as well as ones that we found that are focused on nurse retention and burnout too. And we'll include links to those as well. All right, so let's do some Q&A. So we have a question from Anna. This is for you, Sharon. The question is, do you also work with your physician and provider groups to include them in the culture of psychological safety?
Oh, we do. And, I think a lot of that has been from a standpoint of providing them feedback and in the moment about, how the different relationships went. Now, some are more prone to receive that than others. It's always a work in progress, but I feel like that the one good strong thing is that we have many physician leaders across Emory, and I think I have not yet found one that wasn't willing to be a partner with me to correct a behavior. And so I think that that's the key in providing that direct feedback, and really both of you functioning from a platform of, I don't want there to be anything that builds a brick wall between this nurse and this physician over a patient issue, because that's where the free flow of information has to occur, or the patient won't have the optimal outcome. So we include them, and it's a work in progress.
Got it. Okay. And the next question is more tactical in nature for you, Sharon, and it's on the topics of resilience and retention. Is there any specific training or education that you provide or include for providers?
Well, a lot of our leader development is interprofessional. I mean, we do have some nursing only leader development courses. I have an incredible person. We call her our retentionist. Her name is Millie, and she is an incredible, has incredible insight about situations, and she has her way of navigating and coaching many of our leaders in order to, help them to be able to implement some of the things they learn in our leadership forums. And so I always appreciate her involvement in her interventions. But, having interprofessional learning is one of the important platforms to really giving people a place for them to practice those behaviors before the stakes are high. And we also have several interprofessional governance. Like if you look at it, we don't just have nursing shared governance. Many of our professional councils are nursing, but we also have a few, like in our orthopedic and spine hospital, where their main governance council is interprofessional. So, I think to think about the different forums where you can involve people at the table when the stakes are low, it helps them to be able to execute on behaviors when the stakes are high.
Got it. Okay, so this is a question from Delphine. And it's on the topic of wellness, which Sharon, you mentioned earlier in your presentation. Are there any specific strategies or activities that you've deployed that address the wellness of the nursing staff?
We've got a lot more to do, but during the whole, throughout the pandemic, we have an incredible leader here at Emory. His name's Tim, and he is a national expert in well-being and resilience. And he really taught us a lot and created a lot of listening sessions for nurses to be able to sit with him in groups and talk about what they were seeing, feeling, and doing. And you know, he visited units that were some of our high risk units. And when people invited him in, I mean, he was in our ambulatory sites as well as our hospital sites, really working with people. I worried a little bit about his own well-being, but he is a very balanced individual and did a really good job just helping people give voice to what was going on.
Got it. Okay. I think that, and then I think we have time maybe for one more question. This one's actually for me. How do companies and facilities partner with Incredible Health to assist our talent acquisition teams? So we'll be following up after this call, so you'll have the information and the links that you need to kind of book time with our team. But essentially, we collaborate with the in-house talent acquisition team in order to support them with hiring permanent and experienced nurses. And so it's very much a collaboration. And so happy to share more information about that after this call as well. Any other last minute, questions? And one more question came in for you, Sharon. How has been the implementation of flex work conditions, whether it's telework or adding more part-time shifts? Has that had any impact on nurse well-being?
Well, the only place we've measured burnout is within our critical care units. And what we learned there was the burnout was higher among the nursing group of clinicians than it was physicians or APPs. And so we really have left it up to the unit leaders. They're the closest to the work, and we have followed many different paths of innovation related to their staffing, and we just let them do what they think works best for their unit and within our HR requirements, so that we can be as flexible and nimble with our teams as we possibly can.
All right, fantastic. Thank you so much for your time today, Sharon. We really, really appreciate it. These are our emails if anyone wants to get in touch. And we will certainly follow up with everyone with the recording of this presentation, as well as links to some of the academic articles, as well as how to get in touch with the Incredible Health team. Thank you everyone for joining. We had lots of we had 130 attendees at some point, and appreciate all the engagement. And thanks again for your time as well, Sharon.
Thank you. You're welcome. Good luck, everyone.